Musculoskeletal conditions cause the highest burden of disease in Australia, and in fact amongst the highest worldwide. The major contributors to this musculoskeletal burden of disease are low back pain, neck pain, and osteoarthritis, particularly because many Australians with these conditions develop long-term pain and disability. People with these chronic MSK conditions often seek opinions from many different health professionals and are too frequently referred for imaging in an attempt to identify a pathological diagnosis and potentially to determine prognosis. The data here show that MSK conditions combined constitute the highest total burden of disease. That is, adding other MSK plus back pain and problems plus osteoarthritis contributes almost 10% to the burden of disease. The possible reasons why musculoskeletal problems cause such a high burden of disease are potentially that, firstly, there are many clinical guidelines, but they're often poorly implemented in primary health care. Secondly, it's been difficult in the past to identify patients at medium to high risk of poor recovery. And finally, this difficulty in identifying risk often leads to ineffective or inappropriate interventions. These figures show that in general, management of musculoskeletal disorders in primary health care in Australia is quite poor. For example, on the left panel, you can see that people with neck pain or whiplash are way too frequently and mostly inappropriately referred for unnecessary imaging procedures. Also, management often involves reliance on passive treatments. You can see that the middle panel shows people with low back pain are provided with appropriate advice on management in only 21% of GP consultations. But most surprisingly of all, in the third panel, you can see that active therapies such as exercise are only recommended for 13% of patients with knee osteoarthritis. And this is despite the unanimous recommendation in all guidelines for active therapies, including physiotherapy. It's evident that Australia needs a solution to this really enormous healthcare problem.
To develop a solution, we assembled a team of clinical and research experts. Our team comprises Australia's clinical and research experts in musculoskeletal disorders and arthritis, and international experts in stratified care. The strength of our team is translating research into clinical practice. Our professors are world leaders in research in low back pain, neck pain, whiplash, and osteoarthritis. Our clinical specialists are clinical leaders and educators in disciplines such as physiotherapy, rehabilitation medicine, psychology, general practice, orthopaedic and neurosurgery, rheumatology, and sports medicine. Our solution is to implement an efficient health service delivery model. Firstly, our team have developed validated tools that can accurately determine who will recover well and who has a poorer prognosis. The tools are easily administered, and you'll hear more about this evidence supporting the use of these tools from Professor Nadine Foster later in the presentation. Next, we've developed a matched clinical pathway of care. Those with a good prognosis or low risk should do well with minimal intervention, and you, as a primary healthcare professional, can advise these patients that they should recover soon. To assist you, the resources on My Pain Hub contain up-to-date information on advice, imaging, lifestyle factors and exercise. My Pain Hub also provides links to useful websites for each condition, such as low back pain, whiplash, and osteoarthritis. Professor Lyndall Trevena, a professor of general practice, will also outline the information that you could say to your patients, and I'll demonstrate one way to do this. So in contrast, people at risk of poor recovery have a poorer prognosis, and they may require more complex care directed at some of the risk factors or the individual circumstances. Our care pathway suggests that these patients be referred to a clinician who specialises in musculoskeletal disorders. These are often specialist musculoskeletal physiotherapists, but could also be general practitioners or other health professionals with musculoskeletal expertise. Later, members of our team will explain what comprehensive domains of assessment that they may undertake on the patients that are referred to them. Finally, specialists from other disciplines will explain the indications for referral to them. For example, people with musculoskeletal disorders with high psychological distress may need referral to a psychologist, whilst patients with osteoarthritis may need to see a rheumatologist, and a few patients may require surgery. Our Care Pathway provides advice on when to refer to these disciplines. And we hope this initiative helps you manage people with musculoskeletal disorders efficiently and effectively.
So stratified care involves targeting treatments according to patient subgroups, and that is in order to try to maximise treatment benefit, reduce potential harm or unnecessary treatment, and increase healthcare efficiency. Subgrouping and targeted treatment is particularly appropriate for musculoskeletal problems, and that's for a variety of reasons. Firstly, the wide individual variability in prognosis, also the wide range of treatment options that are available to patients, and of course the variation in response to treatment between individual patients. Okay, so the challenge then is, how do we achieve this? How do we actually better match subgroups of patients to treatments in ways that ensure the right person gets the right treatment at the right time? Well, there are three broad approaches to stratified care, and broadly these are based on either causal underlying mechanisms, responsiveness to treatments, or patient's risk or prognosis. And it's this last approach that we're taking in this study, seeing if by matching patients to treatment based on their risk of a future poor outcome, we might be able to improve things for patients and the healthcare system. So there are several risk assessment tools that have been developed with which to try to subgroup patients into these prognostic subgroups. The one that we're using in this study is called the Örebro Musculoskeletal Pain Screening Questionnaire, and we're using the short version of that. This tool was developed and validated to predict time to return to pre-injury work duties following a work-related soft tissue injury. The tool has 10 items, and it includes factors such as pain intensity and duration, fear of pain, depression and anxiety, sleep, ability to do light work, and expectations about normal work duties. The tool is scored from 1 to 100, and scores under 50 identify those who are not at risk, and those 50 and over identifying those at risk of delayed time to return to work. Or to put it another way, identifying those who are at risk of developing work disability. This tool has been validated for use in occupational health populations and in primary care populations, as well as for people with both acute and chronic pain. Recent but as yet unpublished research by the team here in Sydney demonstrate that this tool also predicts general health status, such as physical health. So in this study we're going to use this tool to subgroup patients into either those not at risk or those at risk of delayed time to return to work. And these two groups will form the basis of the stratified care intervention in this study.